Good afternoon, everyone. My talk is pre-recorded. Good morning, everyone. So today I'll be talking on PDA closure with only venous access. Percutaneous closure of the patent arterial duct began in 1966 with the development of the balloon plug by Postman. If you note the accesses which were used over the years, the initial deployment was primarily through the arterial approach, although both the venous and arterial approach was taken by Postman and the initial device by Rashkin. And in 1980s, we started moving towards the venous axis for deployment. And the same happened in the 1990s as well. And then 1998, when the ADO occluder came, the venous axis was more frequently taken. In the modern day, we have devices which use the venous only approach and the arterial only approach, although one has the option to switch to either. Why was the arterial axis used so frequently in the earlier times? The advantages that arterial axis permits is pressure monitoring in the aorta and in the left ventricle. Aortography was almost a routine to delineate the duct anatomy and to roll out coarctation and to select the occluder for closing the duct. And aortography was done prior to deployment and post release of the device as well. Well, we should remember that in the 1990s and early 2000s, complications were quite frequent with duct occlusion, including hemolysis, incomplete occlusion, besides embolization and narrowing the adjacent structures, which is why aortography was so frequently used. And when the switchover started to the venous approach, people still continued to use angiography to delineate both the ends of the duct, and the lever face was used to delineate the arterial side as well. In the modern era, interventional echocardiography plays a cardinal role in PDA closure, especially by the venous approach. Uh, uh, Duct anatomy can be reliably estimated, can be reliably delineated by echocardiography, and it is used to identify and rule out associated coarctation or branch pulmonary artery stenosis. Evaluation of hemodynamics is primarily done through echocardiography and clinical examination, and need for catheterization is limited to the setting of significant pulmonary hypertension. So indication of closure is also identified with at the level of echocardiography itself. So is the selection of device type and sizing as well. Angiography can be done in the modern era by the venous approach as well. The use of a pigtail catheter through the antegrade approach permits angiography without the need for an arterial access. In selected small children, we can abbreviate the procedure by using a hand injection through a sheath with the wire park in the descending aorta. An antegrade approach permits angiogram without the need for an arterial access. The conventional duct occluders, that is the Amplatzer duct occluder and its congeners, are all designed for deployment from the antegrade venous approach only, because it has a large disc which is meant to be positioned in the aortic side. This is unlike the ADO2 device, which permits deployment through both the venous and the arterial approach. And this has no fabric. That is the essential difference between an ADO1 and an ADO2, besides the presence of the two retention discs, and cannot be used for window type ducts or for hypertensive ducts. The application of the venous approach for ductal closure permits us to close ducts in small infants and preterm babies, as in this case, which we closed very recently. A 3-kilogram infant who was 2 months old and with heart failure was successfully, the duct was successfully closed using a ADO2 additional size 5x4 device. So, as mentioned, ADO2 additional size and piccolo occluders are the ones that are applicable in preterms and small infants. The ADO2 additional size is essentially a miniaturized version of the ADO2 in that it has flatter and smaller retention discs with less protrusion into the aorta. Although both the venous and arterial approaches are feasible with this device, it is preferable to be deployed through the venous approach so that can be used in small infants. And the Piccolo uh, has been approved for use for children as small as 700 grams beyond the third day of life, provided the PDA is less than 4 millimeter at the narrowest end and is at least 3 millimeters long. Again, venous approach is preferred for children less than 2 kilograms. When you come to percutaneous closure of hypertensive ducts, venous approach is almost always mandatory because the need for cardiac catheterization and balloon occlusion tests can be reliably done through the venous approach itself. And the venous access is more forgiving to deploy larger sized devices. Hypertensive ducts are primarily closed using a muscular VSD occluder, as shown in this case, although this can be deployed from the arterial approach as well. Uh, uh, Veins are more forgiving and larger devices can be more safely deployed from the venous approach, and the screw tends to remain on the pulmonary arterial side rather than the aortic side, which gives better control and less chance of thrombosis. For long tubular ducts, one can use the multifunctional VSD occluder or the Conar device, which has screws on either sides, two discs and a waist. And the vascular plugs can also be employed in this scenario. The modern day knit occlude coils are designed for deployment through the venous approach only, provided the child is older than 5 kilograms and the ducts are smaller than 4 millimeters. And the only issue with this coil is that it is associated with more frequent residual shunt. Essentially, ducts of all morphology can be closed percutaneously in the modern era through the venous approach with the plethora of devices which are available for use. Some of the nuances in closing long tubular ducts is that the venous approach permits better control of the aortic disc with lesser chance of DTA occlusion, and also the screw remains on the pulmonary arterial side, and we can do angiography for pulmonary artery distortion prior to release of the device through the venous approach. Another aspect to be cautious about from the venous approach is the occurrence of duct spasm, in which case one can defer the procedure for 10 to 15 minutes to allow the spasm to wane off, or we can deepen the plane of general anesthesia or switch over to general anesthesia. If you have narrowing in the aortic end of the duct, it is almost always related to spasm, unlike narrowing in the pulmonary artery end, which may be due to natural narrowing of the duct as well. When another challenge is to negotiate the sheath through the duct in very small infants. It is always preferable to use a stiff exchange wire and park it deep within the abdominal aorta or iliac vessels and follow it with gentle coaxial over the wire sheath advancement to safeguard the right heart structures. The venous approach provides alternate venous accesses for closure should the femoral veins be not available. As in this case, where we closed a duct from the jugular approach in a case of IVC pseudo interruption. So shall we ditch the arterial access for PDA closure? Well, not entirely, because arterial access still is relevant in ducts which are associated with coarctation, and in PDA closure with substrate for coarctation, but there are no gradients at baseline. It is always preferable to assess it through an arterial approach. And assessment of the LV end diastolic pressure is advisable in large ducts in adults with LV volume overload or diastolic dysfunction, which may worsen with the duct closure. And another unique scenario is the option of PDA device closure without fluoroscopy from an arterial approach, which is not feasible from the venous approach. This is how duct closure is done without fluoroscopy at our institute, where transthoracic echocardiography can reliably guide the closure of small arterial ducts using ADO2 fluid. And surgical, we still have to rely on our surgical colleagues to close ducts in preterm babies below 700 grams, newborn infants with the ducts diameter more than 4 millimeter, or when the duct is more like a window type. In those with pre-existing moderate to severe LP origin stenosis, it's better to evaluate it properly and to tackle the LP origin stenosis before proceeding with a device closure, or consider the surgical option as well, and at those increases of radiation health hazards, non-fluoroscopic option is available. So to summarize, vascular complications are less with the venous approach. Applicability for preterms is more with venous approach. Use of large sheath and larger devices are more feasible with venous approach. Early discharge of babies possible with a venous approach than an arterial approach. And one can retrieve the device and reposition the same device faster with a venous approach. However, interventional echo is more demanding in venous approach. Procedural time tends to be shorter with the arterial approach, and non-fluoroscopic closure is feasible with the arterial approach and not the venous approach.